Okay, welcome everybody to Our Experience, the ASCP podcast. I'm your host, Chad, alongside my partner, Tom, from Hansel Health. And we have an episode segment that we like to call Rage Against the Machine. It's probably a little bit more violent than when we originally started having these shows.
Lots of rage.
Well, I mean, we don't want to incite violence.
No.
But that's kind of where we are in healthcare. But our guest today is Gary Puckrein. He is the president of the National Minority Quality Forum. He is a great friend to ASCP, great friend to myself. I like to call him a healthcare philosopher. He's a great follow on LinkedIn. You will not meet anybody that understands the human nature of our healthcare system and where it needs to go. You will not meet anybody more articulate on that topic than Gary Puckrein. Thanks for being on the show, Gary.
Well, Chad, thank you very much for the invite. I appreciate it so much.
So let's talk about, let's start with just Gary, how'd you get here? Go back to the beginning of Gary Puckrein in healthcare.
So certainly there's a lot of meandering. I'll tell you that for sure. I tell everyone, because I'm old, I grew up when there were 4 television stations, right? Okay. CBS, ABC, NBC, and at the time there was a local channel that's now Fox. And my family was the Walter Cronkite family. Came on at 7 o'clock every evening, Monday to Friday, and at somewhere around 7:28 every day he would give the stock market report. And my father didn't have any stock, but somehow it seemed meaningful to him to hear how the stock market was going. I always said, what's more important to me is how many people died today? What did they die of? Because I always thought money's fungible, but human lives are not fungible. And so I always had that curiosity about me. And went off and I get my doctorate in history from Brown, so I confess all my sins. I'm not a clinician. I studied Galen and Hippocrates and Aristotle classical medicine. I was tenured faculty at Rutgers and got kind of bored there and left and joined the Smithsonian and published a magazine for Smithsonian for a number of years. And that helped me to understand zip codes. So when you're in marketing, certainly consumer marketing, zip codes are your best friend. And there was a lot of analysis done in the 1970s, 90s that looked at zip codes and predict how what car you would buy, whether you take a trip or whatever. And I learned a lot by those zip codes. So in terms of race and ethnicity, there are about 40,000 zip codes where people live. 70% of African Americans live in 2,500 zip codes. About 72% of Hispanics are in 2,500 zip codes. 80% of Asians are in 2,500 zip codes. So when we begin to talk about the lives of minority populations in the country, they live in very specific geographical locations. So when I left Smithsonian, I decided that I wanted to help minority publications that, they had publications, but like the National Medical Association, they weren't publishers, so they weren't really getting value. So that brought me into the world of medicine, took me out of classical medicine and brought me into the real world of contemporary medicine. And what I quickly found out was that they weren't doing zip code analysis. They didn't understand health patterns at the zip code level. So I decided that I wanted to collect health data by zip code. And so that started, this is before anybody was talking about big data and analysis and AI, where, you had an external drive that was 250 gigs, any 250 gig drive I had to have in order to collect meaningful data. But we've been collecting health data now for about almost 25 years. We have a database of over 5 billion patient records, collect data on about 160 million lives a year, covering well over 100,000 different conditions. And in going through that data, I think one of the things that I learned very quickly, highly predictive. Data is highly predictive. You could tell how many people are going to go on dialysis at a zip code level, how many people are going to have a cardiovascular event in a zip code. Mortality rates are about 1% to 2%. a month in the Medicare program. I mean, all that stuff is just absolutely predictable. And it helped me to understand that we have the capacity to intervene. If something is predictable, it means that there's structure there. So there's some sort of structure that's driving the outcomes. And so we need to understand what those outcomes look like. So that's sort of my pathway to all of this.
Well, and I'll say from our perspective at ASCP, I've been here for coming up on 7 years. I met you very early in my process here, and we've worked together on a couple projects, but just the realization about zip code data, it sounds like a very, cursory thing to say, like we look at information by zip code. I think intuitively everybody's like, yeah, that makes sense. Like the way that data can be used, it could be used to identify to a political candidate what the predominant illnesses are in the zip codes that they are either running to represent or are representing, and it frames how they talk to their constituency about healthcare. I mean, I think that is super interesting. The predictive things and the way that healthcare might apply their systems to the country looking at zip codes is the other sort of fascinating thing about this. Like some places, they don't have to worry too much about, disease X, but other places, disease X is a major contributor, a major issue. Whether it falls along minority lines or racial lines, whatever it is, it's that data that ends up driving our response. And I think it's fascinating that you do that and you collect that data. And that's got to be just unbelievably powerful, especially in the face of a healthcare system that I think we vacillate around. Well, it's one of the best in the world, maybe, or it's completely broken. And I think we probably all lean toward completely broken.
Well, it should drive a response. It
Right.
sounds like that, this is in a situation where you could even say, hey, we can prevent maybe
Right.
this disease state or this comorbidity here if we treat this population with proper medicine.
Yep.
Absolutely. And one of the things I love about your organization, you're treating what I describe as the vanguard, right? These are the people who are at the front line, at the edge of our science and mortality. And you can expand that boundary by being able to treat them appropriately. And so I think the population that you work with are the vanguard in the sense of we want to extend those boundaries of longevity, and that's where we'll learn from the group that the patients that you work with.
And I love that description because I think if you work in this industry long enough, you're working in long-term care pharmacy, taking care of individuals in skilled nursing homes or even into assisted living, and now today, even out into the community settings, what you're really doing is you're saying, for 55 years, we figured out how to take care of people at a nursing home level that were very sick, comorbid, lots of medications, and we've learned so much about them that we almost have the antidote for the people in the community so that we don't allow them to become that. And then that's really what we're all trying to do. How do we use this information that we've experienced and collected to keep that person in their home so they can enjoy their family and have a high quality of life and not end up. No one wants to go to a nursing home. I've yet to see somebody raise their hand when I say, who's ready to go to the nursing home? No one raises their hand. But yet we sit on all this data and opportunity to take that information and push it out, but we're restricted by a system that certainly doesn't want to pay for nursing home care and fights tooth and nail to not pay for it, but they're also not willing to pay for what needs to happen on the front end, on the preventative end, to not have to pay for nursing home care later. And that's the challenge, I think, that we face in this healthcare system.
So, Gary, how do you guys handle that? How on Capitol Hill with senators or Congress, how do you guys able to take this quality data and get that to the right people?
No. So let me add another piece to the story by way of answering that question. So several years ago, I was in Costco, and Isaac's book on Einstein was on Remainder, big, thick book, and a couple of dollars. I said, what the heck? I don't know anything about Einstein. It's only a couple of dollars. And so I picked up that book, and I kicked myself afterward because, did a lot of history, but never did the history of science. And so got myself introduced to the history of science and became very fascinated with the whole history around quantum mechanics and all of the things, that whole revolution that happened in the 1920s that has shaped not just the 20th century, but is now shaping the 21st century. So where am I going with all this? One of the founders of quantum mechanics is Erwin Schrödinger, Nobel Prize winner, did the math for the wave function. He did a public lecture in 1943 called "What Is Life?" One of the outshoots of that lecture was the genomic revolution. Crick and Watson sort of got their start in looking for the genes that were passing along hereditary material. What Schrödinger was saying is, I understand atoms and how they bond and how molecules and things get shaped, and so there's got to be something at the cell level that is passing along this hereditary information. And the other thing that he said was that was really important that I've come to appreciate is that there are physical laws around which life is emerging. So when we think of every human being on the planet Earth, they all are here because of the way in which atoms bond together, make the proteins. All of every organ in our body is running because of those physical laws. And so when you think about, as we learn about the laws and create new medicines and diagnostics and devices, we're using all of that science to do that. But where we're not using that science is in healthcare policy and finance. And so what we are saying to members of Congress is, wait a minute, guys, you have to follow the science too. Because when you set up policies that are misaligned with the science, is CBO scoring aligned with the science? I don't think so, right? Is formularies aligned with the science? Probably
right.
not. They're not. Sorry, right? But it's not just that you're misaligned with the science. What it also says is that you're introducing chaos into the system, because the system is built to keep us healthy, and you're introducing these elements in the system that are misaligned with the science. And guess what? That's why we have these disparities. So you take that misalignment and you apply it to the zip code, and you begin to understand why life expectancy is so short in certain zip codes, why people end up going to the hospital when it's preventable, why we're not pushing that frontier on longevity even quicker. And that's basically the point, right? That there really are rules to the road here that have to be followed. And there is no safe harbor provision for any member of Congress, any president, any senator, everybody, patients, doesn't matter. We all have to follow the same set of facts and rules. And that's what we try to deliver to members of Congress by saying to them, yeah, you got 30% of the people in your district who suffer from diabetes and they're getting amputated. And guess what? We have CGMs and GLP-1s and a whole bunch of stuff that they're not getting. And there it is. So I think that's the change. That's our future in healthcare, is to get everyone aligned with the science. And to your point earlier, Chad, that's why people are so aggravated with the payers, right? Because they're introducing chaos into the system and denying people access, and they think that somehow that's their function in the system to do that.
Right. It's a system of denial. Yeah, there's two things I think that happened. Maybe one isn't really last year, but we had the tragedy with the United Healthcare executive. We're all now familiar with what happened, but it really wasn't that event. It was the social media response to that event that was sort of culture shifting. The reaction wasn't, oh my God, that poor guy and his family.
Right.
The reaction initially was, well, he makes $10 million a year. He's the executive of one of the big three insurers, and he denies people medication, denies people care all the time. He's killed a lot more people,
Like he deserved it.
like he deserved it. And
Yeah.
obviously, a rational person doesn't think anybody deserves to be killed like that. But we have to have some response to this growing public sentiment that they're not satisfied with this system of denial that we've set up. Everything is about not getting something that you're either paying for or you think you should have access to. And that's one. The second is the GLP-1s. I know that didn't probably happen specifically last year, but I used to believe after atorvastatin, this is my small brain, that we'll never have a blockbuster medication. There will never be a Lipitor type medication again. The human body is too specific. You might find great medications that work in some subsets of people, but you're never going to have this wildly successful drug. And you could argue that maybe even Lipitor is not that wildly successful, but it's a game changer in medicine. The GLPs are that next drug. They are game changers.
Yeah.
And this is a drug that started with celebrities buying it because they could afford it, because it made them lose weight, and they're so focused on image that it quickly became a have-nots kind of scenario. And we had all this noise around them. Are they good long term? Yeah, you lose 30 pounds, but what happens in 10 years? We don't know. Like, are they safe? So we're going to restrict them. And who doesn't get them? The old people, the poor people.
Right.
And it's not right. And rationally, and I'm not saying that these are, again, God's gift to medicine, but if you told me, hey, you take this drug, you're going to lose 30 pounds, it's going to alleviate your type 2 diabetes, but in 10 years, we're not sure what it's going to do to you, I think most people would say, yeah, but what is 30 extra pounds or 50 extra pounds going to do to me for 10 years? Like, it's worse. It has to be.
Well,
So
back in the day, Medicaid didn't even pay for birth control and those type of things.
Sure.
Obviously, that cost the insurance company a lot more money. Uncontrolled diabetes or whatever it is going to cost the insurer.
So, but it's shifting the mindset of the healthcare system to believe in that and be like, hey, wait a minute, I know these are expensive drugs, but if that person loses 30 pounds, in 10 years, they might not be in a nursing home. They might not have an amputation. They might not have all the sequelae of uncontrolled type 2 diabetes and other issues from carrying that weight. So maybe we should invest in that. Maybe access should be more readily available. So I don't know. Those two things I think are things that are shifting the culture, and it'll be interesting how that plays out in our healthcare system. And what your reaction is to that.
Oh, I think there is no other pathway. One of the things that, at least for me, that I've come to appreciate is that when you understand that, we function because of a set of ways in which atoms bond and molecules and all of those things work together, you understand that the job is really to optimize those things. And there isn't any future. There isn't any second doorway. It's not the price of right. There's not three doors.
Right.
There's only one door, right? And the issue then becomes, how do we get our healthcare system on the policy side? Because when you do clinical trials, you know that that's the case, right? But you go to FDA and they're looking at safety and efficacy, they're following the science. Right. It is when it comes outside of FDA into the marketplace that you have payers, be it commercial or government payers, who come in and think that they can deny access or limit quality or quantity or whatever it is they got in their mind, and that's a free lunch, that there isn't going to be any adverse consequences for that. And the only reason why those adverse consequences exist because we don't measure them. Nobody says, "Oh, excuse me, if I don't give you access on this formula, what happened to you?
Right.
What's that measurement look like, right?" And that's the point that we have to get everybody in our healthcare system on the same page. And what I find fascinating is that payers, their lives are constrained the same way. I don't get it, right?
Yeah.
It's not like your family isn't going to feel it, but I think they kind of feel like, well, I can go pay for it if I want to, and so I can kind of get out of it. But the answer is probably not. That we're sort of all tied into this together.
Well, I mean, one example I'll bring up just from my past is I cut my teeth on those cholesterol drugs. I did a lot of work with those medications. And if I was in front of an audience of physicians and I asked them at the very beginning when we had Zocor and Mevacor and Lipitor, what one are you on, doc? Lipitor. Every answer was Lipitor. The second that Mevacor and Zocor went generic, simvastatin and I can't remember the other one. What's the other one? Mevacor.
Mevastatin?
I don't know. Anyway, as soon as they went generic, the payers all forced everybody to generic. And we knew at the time that Mevacor and Zocor had drug interaction issues with calcium channel blockers and all kinds of drugs, predominantly that an older person would have on their profile. And the reaction from the insurance company was, well, yeah, after they get switched and they demonstrate that they've had a drug interaction problem, then we'll allow them to get to one of these other Pravachol or Lipitor. And I'm like, I can't believe that the answer is, we know this is going to cause a problem, but we're going to make the problem happen so that you prove that you need the expensive version. It was fascinating to me when the answer could have been much simpler. Hey, you're on verapamil or diltiazem, so we're not going to give you simvastatin. But they did it anyway. They did, and to your point, they probably did it to themselves, or they bought their way out of it.
The one that drives me nuts is hepatitis C.
Yep.
They can actually cure it.
Yeah.
You can actually cure it. But you're saying, well, we need to wait till you have cirrhosis of the liver.
Right. Till it's real bad.
Yeah. So they're the plan, right? Come on. What are you talking about? You cure the damn thing,
Yeah.
right? But that's what people are angry about, right? Because you have them living with hepatitis C because you've decided that you don't want to pay for a cure. Or you have patients who have cancer and a plan says, well, it sounds like it's experimental to me and I don't want to pay for it. That is not a system that's viable any longer. I think the science is moving so quickly and our capabilities are demanding that we reimagine how we do these things.
So Gary, we've got, we talked the last 20 minutes about all the negatives and bad stuff, but give me some hope. We have obviously a huge change in administration, where we're from Senate to House and now president is all one party. We've got a new, obviously, the CMS leader is going to be new. We've got a lot of changes. And then we've got an an aging population that's aging pretty dramatically. But anything that you've seen or picked up on that gives you hope that is going to be some improvement in American healthcare over the next several years?
I thought you wanted this to go positive.
I'm hoping he's going to say yes. I'm hoping the answer is yes.
I think the way I would answer that question is it's a matter of political will, right? Do we have the political will to give ourselves permission to change the system? The science is already there. This is not speculation on what it is we have the capabilities to do. We've been doing work in the cancer space, for example, and what we know is that we can bring cancer under control in the same way that we did to HIV. I mean, the science is getting that good, right? But it's really about political will. And I think that'll happen. I think that's our future. I think that's exactly where we're going to go. I think it'll take some strong advocacy, some groups like yours, to mobilize. But that's the power of democracy. And I think as people come to understand um, what the system is actually capable of doing, they'll want that. And so I think that's why I said in the middle of any storm, there is great opportunity, and I think that's where we are to seize this moment and build a system for ourselves.
I want to pick up on that because you brought up the cancer, and I want to make sure we got to that. You've done a lot of work with screening and identifying people that have, I think it's the genetic, abnormality that would lead to a particular cancer. How has that gone? I know what your goals were. People need to get screened, and if you find out you've got the risk, then you can start the treatments earlier. There might be things you can do earlier to avert full-blown cancer. How has that gone so far?
Well, again, I'll answer the question this way. So we're about to launch clinical study in Houston, Texas, and in Flint, Michigan, and we're going to have 20 sites up over the next couple of years. So where the science is right now with cancer is that changes in blood chemistry, this is even before you get to stage 1, changes in blood chemistry can signal that cancer is beginning to develop in the body. And so what we're doing in Houston and in Flint with some partners, we haven't announced anything, so I don't want to put out their names right now, is to surveil the population, to go in and enroll community folks in the study, follow them year after year, looking for basically shedded DNA and other changes in blood chemistry that signal that cancer is beginning to develop. Now, the what to do with that is part of what the learning is about. Certainly when they get to stage 1 of the new therapies and things coming out of new therapies that will work. But that's that journey way upstream in cancer that will allow us to control the doggone thing even before it. So I would tell you probably over the next 15 to 20 years, and hopefully sooner, that metastasized cancer will be a rarity, that we will have moved so far upstream on cancer that we will make dramatic changes. But I can say that about a lot of other therapeutic areas. That's the point, that the science is getting so good that what we're going to be able to do in terms of interventions are going to be incredible.
That's amazing. That is positive to hear that kind. I'm glad that you're starting that project, that surveillance project, to bring that to the forefront. It's that kind of thing that I think when something like a GLP-1, that thing kind of blindsided everybody, came out of nowhere. But it probably didn't quite come out of nowhere. I mean, it was a medication path researched and developed, and people saw what it was doing because they were doing these kinds of surveillance studies and said, hey, wait a minute, people are losing weight on this thing, and then bam, catches fire. As soon as somebody in one of these studies, hey, we were able to identify this cancer this early and get them on this treatment, and they're not getting metastasized cancer or bad cancer anymore, or maybe you're solving the cancer, then it's going to spread like crazy. And then it's going to be again in front of the payer of, are you going to pay for this? Yeah.
Yeah, then they're going to say, well, you're not really symptomatic by my rules. You have to have some metastasized cancer.
That's right, right? Oh my God, we laugh, but we laugh, but I think it's on somebody's desk somewhere.
Yeah. They've had a cure for cancer for 10 years.
Oh yeah, right. All right, so what else is going on, Gary, in your world? Like, what is NMQF working on? I know you have a summit that comes up every spring. Talk about that, and how can we follow your work?
Yeah, so certainly, we're working on our summit. That is April 28th and 29th here in Washington, D.C. We've got another conference that we're working on. if you go into the world of physicists, they're really at the way out there in the vanguard, and we want to bring them together with payers and providers and patient advocacy organizations and organized medicine to really start talking about the reimagining. Because one of the things I've come to appreciate about the physicists is that they're data, number driven, and they can help us quantify. And so health is going to become a math problem at the end of the day. And so I think that's really where we're leaning into is how do we bring AI into it, teach AI to help us be a lot more predictive. I just think the world is wide open for us. But I think the priority has got to be on reducing patient risk and not shareholder value. I think the shareholder value folks, they've had their day in court. And it's not that we don't want you to make a lot of money, but we want you to deliver the product that we need and in a measurable way. No more of this lack of transparency. You got to belly up to the bar and show your numbers like everybody else.
You know, it's funny you say that. Over the holidays, I was back home in Cincinnati and was talking to my dad. My dad is not a healthcare person. I was the second person in our whole family to go into healthcare. His sister was a nurse, but he was an HR director for Cincinnati Gas and Electric Company in the 70s. And he just brought up kind of out of nowhere. He understands kind of what I do and what I do in healthcare, but he brought up the concept that he knew when Cincinnati Gas and Electric signed up for health insurance for the first time, and they moved from a nonprofit health insurance model to a for-profit health insurance model. He's like, at that point, we all knew this was not going to go well. And I'm like, I'm not old enough to remember what healthcare was like before you had sort of employer-based insurance. But I mean, it did strike me as, so there was a time when they weren't for-profit companies, and why did we move away from that? I think, obviously you can manipulate a nonprofit company to generate massive return as well, but there does seem to be something to the idea that should we be making money on healthcare? Should we be making money on the sick to support the well? Like, we're kind of doing it wrong. Like, those dollars need to get reinvested into healthcare. You can still be a company and you have to survive. But to your point, Gary, like, do we have to make billions of dollars as United Healthcare or these other companies? Or can we use that to support the healthcare of everyone in some way?
Point.
So I don't know.
Yeah, I think that's where we're going. I support the marketplace in terms of healthcare and having for-profit entities in there. But they have to show their value, right? When people buy healthcare, pay their premiums, they do so with an expectation that when they need the care, it will be there for them.
Correct.
And the idea that your plan in a moment of need is going to tell you that, well, we can't afford you, is not a solution. And so that's probably the hardest part of the conversation that has to be had, is how do you take, I think United Healthcare is a Fortune 20 company, right? How do you tell a Fortune 20 company that your business model needs to change?
Yeah.
But that is the conversation.
Yeah, there was something that came out, I just read it today, the Shkreli Awards, named after Martin Shkreli, who's the guy that capitalized on that, cornering the market on a particular generic drug, if you remember that story back in the day.
Oh, yeah.
He got in trouble. So they have these awards called the Shkreli Awards, and they go to the top 10 healthcare companies that did the most devious things. And the one I remember from it's a good list of 10 things that you're like, I can't believe. But the one was like they retroactively denied an $86,000 ambulance it must have been a helicopter ride for a beneficiary that had a heart attack and had to get to a hospital from a rural area because they said, you really didn't need to do that. And I'm like, how do you go back? How do you saddle somebody with an $86,000 retrospectively? Like, I get it if you're like, hey, listen, the docs think you can make it in the ambulance. You don't need it to be air cared. But after it's over, I mean, I know that's kind of a weird example, but I'm like, that's
what they do.
Their incentives are misaligned. It does not make sense.
In our world, PBMs go back 6 months later and try to find.
Yeah. Oh, yeah, you didn't put the last name of the nurse on that script that got called in? We're not paying you for the entire script that you dutifully gave to the patient and they consumed. Yeah, I get it.
No, don't tell me they're doing that. It's not
they do that. Oh, my God, they do that every day. Absolutely, every day. There was a pharmacy that was a nonprofit clinic pharmacy in Cincinnati, and it was located in the first floor of the clinic building. The federally qualified health clinic where the docs is on the second floor. So the only scripts that pharmacy filled were from the docs on the second floor. So the nurse on the second floor would call down to the pharmacy and say, hey, it's Sarah. Here's a script for this person. They're coming down to get it. The person would come down to get it, and they would take it. The auditing company for the insurance came in, and every script where we wrote down Sarah called this in, they said, well, you didn't write her last name down. And we're like, we have lunch with Sarah. She's from upstairs. This is the only place we get scripts. And they're like, yeah, we're clawing that back. We're not paying for those. Yeah. So that's how bad it is on the insurance. And there's no defense for that.
You have to have a decent-sized long-term care pharmacy has to have almost a full-time employee that's just managing audits from insurance companies. Just to make sure you get the money that you earned 3-6 months earlier.
No, it's bad.
And if you don't, and they see that it's easy to take back money from you, they'll up their audits.
Well, and sometimes they just say, okay, well, that was 4% of your scripts, so we're gonna fine you, or we're gonna pull back 4% of all of that revenue. They won't even find all the exact number of instances. They'll make a estimate.
Claim audit or
right.
Yeah.
And that's in your contract that you were forced to sign. So it's. Yeah, we could have a whole other show on that, Gary, if you're interested.
As you can see, I try to move towards a positive outlook, and we went back negative towards PBM. So.
Well, Gary, thank you for your time. Thank you for what you do. Thank you for being a healthcare philosopher. I love hearing from you and following you. And if people are interested, NMQF.org is where you can find Gary's work. And we'll be at the summit, and we'd love to be at that other meeting with the physicists too. That'd be great.
Well, you've got an invite. It'll be on the way.
All right.
Absolutely.
Thanks so much.
Thank you, Gary.
Well, thank you, and appreciate all that you do, Chad, and your team. Great work.
Thanks, Gary. All right. We'll see everybody next time on Our Experience.